Hey everybody, I'm Nina Crowley. I'm SICA's Professional Affiliations and Education Manager, and I'm here today with Dr. Scott Kahan, who's the Director of the National Center for Weight and Wellness in Washington, D.C. And we're here because we both just got back from Obesity Week in San Diego, California, and I was able to attend Dr. Kahan's talk on raising the bar beyond BMI, treat to target BMI or comorbidity. And it was a really great session, I think, with a lot of interesting talking points that I wanted to dive into a little bit more than the time we had there in California. So welcome and thanks for joining me.
Great to be here with you.
So I loved your talk. I think, one of the things that really excited me the most about it is just really opening up the conversation a little bit deeper about BMI. I know we've all been sort of chatting about this with our patients clinically, professionally in the community. We see a lot about it in the media. And so I thought maybe you could give us just a brief little snippet about, what are your thoughts on how BMI is used right now, and maybe some thoughts about where it might be going in the field, and then maybe we can get into some of the deeper points that you made about that from your talk.
Yeah, so I was specifically asked to speak on this topic, and till I did the research for this presentation, I was sort of a BMI defender in a sense. I would often point out to all the naysayers that, well, there's nothing wrong with BMI. It's a useful first step in patient evaluation. We certainly can't throw it away. So no point in bashing it. And let's certainly move beyond BMI, but in addition to BMI. And as I was preparing this and reminding myself of things that I'd long sort of forgotten with respect to BMI and learned more, I sort of got more and more angry about the use of BMI. And, and I'll speak to this in a second, while I don't think we can go away from it right now for logistic reasons, more and more, it just seems like it adds little to nothing clinically, and often really takes away from good patient management and patient workup. The reason we can't go away from it right now, at least, is that it's so ingrained in our healthcare system, our healthcare payment system, and healthcare policy system. And largely, this has only been for the past 2 to 3 decades. So until the late 1990s, BMI was well known and utilized in research settings and so forth, as well as clinical settings. But it wasn't until the late 1990s that it became formally codified in obesity-related health policy. So the WHO in 1997 defined the current body weight classifications based on BMI, normal weight, overweight, obesity, etc. In 1998, the next year, the NIH followed suit and further codified the BMI weight classifications, and went away from what they had done before, where they had only classified weight based on either overweight or underweight, around a BMI of about 27. It was slightly different from men to women. And then right around that time, in 2 different publications that the FDA did, they made thoughtful guidance for industry on how to develop medications to treat obesity. And as part of those, one, they adopted BMI as the primary criteria for patient evaluation. 2, they defined medically significant obesity such that medication could be warranted based on BMI, in this case, a BMI greater than 30 or a BMI greater than 27 with at least one weight-related health problem. And they published a few other things related to that. But again, point being, it further ingrained BMI centrally in obesity policy. And now we can't get away from it, at least in the near term, even if we want to, because The way that medications for one are approved in part is based on a certain BMI criteria. The way that medications, surgery, and other treatments are allowed and covered by health payers is based, at least in part, on BMI. And so for that reason, we have to calculate BMIs in patients. We have to report and document BMIs for our patients. For clinical reasons, though, that BMI number means little to nothing, in part because while BMI is supposed to be a surrogate for body fat, and it does that well enough on a population level, on an individual level, it's so imprecise as to be meaningless. Two people that have 20 to 30% percentage points difference in body fat percentage could easily have the same BMI. And so it just becomes a big problem because it doesn't even do what it's supposed to do. On top of that, and part of the reason for that, it's a poor indicator of body composition. It's certainly a poor indicator. I mean, it's no indicator of body fat distribution, whether you hold body fat viscerally or you hold it subcutaneously, which we know makes a huge difference in terms of health risk.
Right.
The more I delved back into this and the more I spoke to this, the more I realized that we really need to keep moving farther and farther away as quickly as possible from using BMI as a patient evaluation measure.
And what I really liked, beyond, of course, kind of getting into that history and really outlining the policy, because it is deeply ingrained, and we don't want to get rid of it completely and have there be no way to provide treatment for the excess adiposity or obesity. But I liked sort of your talk about a treat to target approach, and so I think that was unique and fairly new to me in the audience there. Is that something you could share a little bit about what that really means and how people can start to learn more about that in practice?
Yeah, so treat to target is a concept that's been used in a number of areas of chronic disease management, especially a number of areas of inflammatory conditions like rheumatoid arthritis and irritable bowel disease. So it's a proactive disease management process where patients and clinicians work together to develop individualized treatment targets and goals, to implement a process to have ongoing interaction and monitoring and making sure that they're working towards those goals, and we're adjusting treatments as needed to reinforce movement toward those goals, such that people make progress, such that they feel better, they improve their quality of life. And in the case of obesity treatment, their health, their body weight and such goes in a productive direction. And so the treat to target concepts and process have been studied across a number of disease areas and have been shown to be extremely productive, both in terms of improved patient outcomes as well as improved cost efficiency, cost effectiveness. And so while it hasn't been explicitly used in obesity management, I think it fits very, very well for the problem in obesity and for how we can go about addressing it. So again, part of it is individualized target setting, and that target setting shouldn't be based on just a goal BMI or a goal weight or ideal weight, but rather the goal is to improve the health problems that are related to the weight, whether it's quality of life. Those are the goals that we're really trying to get at. And we have very good data from many, many studies over several decades showing that varying degrees of weight loss tend to improve different types of comorbidities. And so if you have some high blood pressure and some high cholesterol, a relatively little amount of weight loss will typically improve those, as little as 3 to 5 to 7% weight loss. On the other hand, if you have significant liver disease, if you have diabetes, if you have poor mobility, while you can start to see some improvements with lesser body weight losses, Usually we have to get more in the range of 5 to 10% weight loss to start to see meaningful improvements. And once we get even higher, 10 to 15% or more, then we really start to see extreme improvements in those areas. Diabetes is a great example. By the time you get to about 15% weight loss, the majority of people with diabetes who lose at least 15% of their body weight, they see full remission of the diabetes, as well as likely in almost all cases, a whole bunch of other areas of improvement in their health and feeling and functioning. So we want to set individualized treatment targets, individualized for each person. We want to make a plan for how to go about monitoring in a proactive way and continuing to work with patients such that we either ensure that they're moving forward and feeling better and seeing improvements in their health, or if things aren't going well, that we're being proactive to work with the patient to adjust things such that they can start to move forward. And then this active management process continues with ongoing assessment, ongoing monitoring, and ongoing treatment adjustments as needed, always throughout the whole process with a shared decision-making and individualized process with patients. So so I think this is an area that could be extremely valuable in obesity management. And again, till now, it has not explicitly been used, although, of course, we use bits and pieces of it in the part of any doctor-patient interaction in obesity.
Right. And I think that shared decision-making approach, I know that you're one of the best ones at doing that and teach folks to use that, but I really do hope that that could be something that really goes along with this, because I've seen that, just be really, practice changing when people can kind of embrace that.
Yeah, absolutely.
So any thoughts about sort of what's next in the field in this area? I mean, we keep hearing about all the medications that are finally starting to achieve some of those weight losses you talked about for diabetes and for excess weight.
Yeah, I mean, look, there's been lots of great development and innovation in the field over the past couple decades, and we're starting to see on the ground a lot of that come forth. For one, in terms of some newer medications becoming available, and remember, we've had really good medications for more than a decade now, and now just in the last couple of years, we have some even better ones, and the pipeline is really impressive. So I anticipate, if we're talking like this after Obesity Week in 2025 and 2026 and 2027, even more so, I think we're going to have even more tools available. And maybe by then we'll have some movement forward in terms of obesity-related policies, such that we're not having to use BMI as the be-all, end-all determinant of whether a patient can get treated with one of these medications or other useful obesity treatments, to determine whether coverage will happen, not based on BMI simply, but based on a better and broader assessment of the patient's health and the patient's potential to improve with that treatment.
I think there was a lot of good application to the policy side too. I mean, I think it's one thing to talk about new research and even about how to, relate that to your individual patient care, but I really see, being able to make big change for the majority of people, and that majority does have overweight or obesity, that we really need to link that to policy. So that was encouraging for me too, especially at this meeting.
Yeah.
Well, thank you for all you're doing in this area, as always, and for your time today, for talking with me. And hopefully, we will see some new talks on all this next year at the meeting.
Absolutely. Thank you. Thank you for having me.
All
And
right.
good
Have
luck
a
to
great
everyone.
rest of your day. Thank you.